where the floor should be, but I could also see a floor coming at me. My mom took me home and she was really concerned. My eyes were going completely different directions. She took me to the optometrist to see if maybe it was just my contacts or something. And he was pretty concerned and suggested that we go to the emergency room. Luckily, there was a nurse that actually wrote on my chart possible myasthenia gravis, but essentially they gave me a referral to neurology and told me to take Tylenol because we thought we were treating double vision and a migraine. We had no idea of what we were dealing with. We got into the neurologist and they told me that they were going to do some tests. And my thought was, okay, you go to the doctor, they name whatever you've got, and they send you on your way with a script. You get better. He told me that I had myasthenia gravis. I didn't know how to spell it, say it, nothing. My mom, I remember, looked at him with these big tears in her eyes and she said, okay, well, what does that mean? Is she going to die? And he said, she won't go downhill real fast. And he patted her on the leg, and that was it. In hindsight, that is so devastating. I didn't know how prednisone was going to change my body. I didn't know how it was going to change my moods. I didn't know what to do to manage all of the side effects. And you're very hopeful. You go to your next doctor's appointment and you're going to say, this didn't work for me. So what now? And in that time period, there really wasn't anything else. So it was acetylcholine reuptake inhibitor, which didn't work well for me, but it did give me ulcers. And then the prednisone, which made me want to eat the paint off of the walls and crawl out of my skin. So within 6 months, it became not only were we treating MG, but now we're also dealing with anxiety and panic. And because I'm not able to restfully sleep because of the prednisone, then I'm being given an antidepressant because I'm told that I'm depressed, which I don't know how anybody couldn't be in that situation. And it felt super lonely. And then I went into remission with all of my pregnancies, and I have 3 children now. I had them starting at 35. My son was born in 2020. In 2019, I was having some flares and we decided to try a selective immunosuppressant. Now, there's so much information and there are things that we know are helping. You know, the questions are being asked and answered. So I think that there won't be stories like mine anymore.
All right. Thank you very much. I'm Dr. Josh Alpers. I'm a neuromuscular physician here at UT Erlanger Neurology in Chattanooga. And I'm going to be talking about understanding the patient journey in generalized myasthenia gravis. And there's a couple of key words I'm going to pull out. Patient journey is one, and another one I'm going to come to is shared decision making, and I'll come back to that. So first off, broad view, classic view of myasthenia gravis. And this is stuff we've heard many times. Myasthenia gravis is a rare chronic autoimmune condition affecting more than 60,000 individuals in the United States. You can see prevalence is higher in the Midwest than the West, but it varies. Ocular muscles are typically first affected, causing ptosis and diplopia, with development of generalized myasthenia gravis occurring in up to 80% and even potentially higher, approaching 90% of patients, usually within 2 years of disease onset, causing problems with swallowing, speech, breathing, and mobility. And nearly 20% of patients will experience at least one myasthenic crisis, which typically occurs earlier in the disease course. So that's a broad view of myasthenia. As we go down a little bit farther, looking at the objective findings of myasthenia, we can class these as ocular, such as diplopia, ptosis, bulbar, dysarthria, dysphagia, jaw fatigue, respiratory, limb weakness, including proximal upper and lower extremity weakness, and due to weakness with finger extension, hand intrinsics, reduced manual dexterity, and then neck weakness. So now getting even more granular from an objective standpoint, this is starting to back out a little bit. As you look across this, you can see fatigability is a significant component across the board. But there are a few other things. Voice quality and tone comes into play, weakness of the core musculature. And on the bottom, we start to get to some vague concepts again with fatigue and cognitive impairment. So symptom frequency, I like this slide for one primary reason, and that's that as we look at the survey that was done of patients of what their most bothersome symptom was, you can see the top three: blurry or double vision, difficulty breathing, and fatigue. So if we back this up about 50 years or so, the goal is to keep patients out of the hospital and to keep them alive. We're now refocusing. Our target is to get patients to treat the fatigue, to get them back to a place that they can have a relatively normal life, that they can get back to work. Our target for therapy has changed and our goals have changed. So this brings us back to the patient journey and thinking about how all of these objective symptoms and physical exam findings contribute to impairment and to disability in a patient. The International Classification of Functioning, Disability, and Health identifies three main areas in which disease affects an individual. There's the objective component, again, impairment of body functions, and then there's the impact, so how it results in activity limitations, participation limitations, and disability, therefore, is this complicated interplay between all of these factors and the patient's environment. Measuring the impact of myasthenia gravis is challenging due to fluctuation in symptoms, and this fluctuation in itself can be a significant source of anxiety as well, with the overall impact containing emotional, social, and economic components. There is an increasing awareness of the importance of understanding the patient journey, leading to current studies, the Digital Prospective Observational Multi-Country Study, the My Real World MG, looking at the impact of myasthenia gravis on patients. And this brings us back to the patient journey and to having patients participate in their journey and the shared decision-making model of treating myasthenia gravis. How do we measure quality of life? I'm going to move over to the right side of this slide, the patient acceptable symptom state, or PASS. I like this concept a lot. It's one simple question I ask my patients. Considering all the ways you're affected by myasthenia, if you have to stay in your current state for the next few months, would you say that your current disease state status is satisfactory? Simple question. Answer is a yes or no. And this is a very helpful, reliable, and a non-redundant reported outcome measure, but allows them to have a say of, yeah, I'm doing well, or I just don't think I'm doing as well as I need to be, which then brings up other things such as the relevance of ocular complaints. Another component of quality of life, another way to measure, is the MGQOL-15. I like this. It's very similar to the MG-ADL. When my patients are in the waiting room, I hand out the MG-ADL and the MGQOL, and I have them fill this out. And then when we come back to the office, this gives me a lot of insight into how it really impacts them. These are things I don't routinely ask during the clinic visit. I don't ask them if they feel overwhelmed by their myasthenia. I may not ask them if they limit their social activity, but as I look down through it, this really helps me to pull out how their myasthenia impacts them. And in turn, it helps us to develop different targets for therapy. Factors that impact quality of life. We can put these into three different categories: physical, emotional, and social impacts. Physical impacts, again, are fairly evident. These are going to be how their physical impairments result in alteration in how they impact their physical activities, ranging from activities of daily living to hobbies. They can't sing in their church choir, which contributes a lot to their quality of life. Or planning and adaptations. I've had multiple patients tell me that they don't go out to dinner in the evening because their jaw gets tired when they chew, and they're afraid if they sit down, they're going to have a hard time standing back up. Physical impacts can result then also in work and financial disability, absenteeism, things like that, and then sleep impairment as well. And we're going to come back especially to the work, career, and financial aspect. Sliding over to emotional impacts, we see anxiety and depression are quite common, as is embarrassment, and social impacts. All this, there's interplay with all of this, resulting in challenges with their partners, with dating, with feeling misunderstood. So here's this nebulous concept of fatigue. Fatigability in myasthenia gravis, that is one of the core components of myasthenia, but this pervasive concept of fatigue also tends to be present in most patients. The prevalence of fatigue in myasthenia gravis is comparable with fatigue in other diseases, and it is significantly associated with their emotions: frustration, depression, and feeling overwhelmed. There's a strong connection as well. When they're fatigued, they're less likely to participate in social relationships, and fatigue is directly related to disease severity, and it can improve with disease remission and or improvement. So fatigue in itself can be a target for management. Myasthenia gravis is a variety of emotional impacts as well. And for the next several slides, there are a couple of studies here that I'm citing for these. I put the percentages up, and I like to see these percentages just because to me, it's if I'm going to have an afternoon where I'm seeing 6 myasthenic patients, this tells me I should expect that in those patients, I'm going to see these various components of the disease manifest. I may not pick it up just on a kind of superficial interview and need to dig a little bit deeper. Depression in about 19% of patients, moderate to severe anxiety in over 2/3 of patients, and depression and anxiety correlate with the severity of their physical symptoms and hospitalization days. Next, moving to social impacts. The first part of this is younger women are more likely to have, there's one of the peaks there from myasthenia gravis, and so family planning is a big part of that. And so there's a higher instance of myasthenic symptoms during family planning, resulting in more than half of women and a little bit less than a third of men indicated that myasthenia gravis influenced decisions regarding family planning. Myasthenic patients with medium incomes or moderate disease severity also reported lower levels of perceived social support, including impacts on health insurance and negotiation, and need for transportation. So this is where the percentages come in. Physical impacts on daily activities. Over a third of patients need help from a caregiver with daily activities, having to make plans around an illness, 40%, losing personal independence in driving, shopping, 24%, which is losing personal independence, having had that happen to me in the past with an ankle injury, that is substantial, and then ability to perform housework in about 38%. Next, we have work. All participants in a recent study reported that symptoms of myasthenia gravis impacted aspects of their work, career, and finances. Over a third had taken sick leave within the previous month, and a higher proportion were unable to work at all due to illness. In one study, limitations regarding employment were present in nearly 3/4 of patients, with 46% incapable of working. A recent Japanese study reported unemployment in 27% of patients, with a decrease in income in 36%. And on a global scale, nearly half of patients with myasthenia gravis may not be employed. And being involuntary excluded in itself is associated with premature mortality as well as a greater use of medical services. Next, moving to financial. Patients with myasthenia gravis have any type of medical care within the previous month, over half compared with about a quarter of the general population. And the financial cost of myasthenia gravis, there's the most robust evidence for direct medical costs, and that's going to translate primarily to cost of emergency care. Increase in cost, healthcare resource utilization with crises and exacerbation, with over 3/4 of patients expressing concern regarding loss of income in this context, which moves us then to the indirect cost. If a patient is not working, they can't make money, and so that also significantly impacts their finances. So shifting gears a little bit here over to, we've been talking so far about how does myasthenia gravis impact quality of life. The challenge currently is a lot of the therapies that we've had for a very long time and are very commonly used are also associated with impact on quality of life. And there's some basic concepts such as pyridostigmine has dose-dependent GI side effects. Corticosteroids. So corticosteroids are very effective medication for myasthenia gravis. Commonly prescribed, may result in sufficient disease control in less than half of patients, but the long-term side effects are fairly prohibitive, including hypertension, osteoporosis, diabetes, cataracts, and that list is not comprehensive. And so therefore, there may be a J-shaped curve for quality of life in association with corticosteroid use. At the beginning, quality of life improves because you have improvement in your myasthenia, but over time, due to long-term corticosteroid-related toxicity, you have increasing side effects which have a substantial negative impact on quality of life. In a recent study, more than half of patients treated with azathioprine or mycophenolate mofetil were felt that their quality of life was improved with treatment, with no significant difference between the two agents. So here's just a couple of other factors to consider when we talk about quality of life with myasthenia. First, MuSK-positive patients. They tend to have an increased reduction in quality of life compared with acetylcholine receptor antibody-positive patients. Next are the ocular patients. There is a tight association between therapeutic outcome and quality of life. Next will be the seronegatives. Seronegatives tend to be younger at symptom onset, longer diagnostic delays, and that delay in itself creates increasing anxiety and depression, but they also tend to have a higher disease severity and more employment restrictions. Next, I'll move to medication compliance. Over half of patients with myasthenia gravis were not treatment adherent. These patients tended to have greater muscle weakness, reduced quality of life, and higher risk of depression. And finally, there are increased challenges for individuals using public insurance or living in non-urban environments. So, how do we improve quality of life? First off, the MGFA grade is a strong predictor of all aspects of health related quality of life. Next point, nearly half of patients are dissatisfied with their current symptom state. Third, symptoms associated with myasthenia gravis, such as depression, anxiety, fatigue, and sleep, a little bit more nebulous symptoms that are harder to treat, they all get better with disease improvement and remission, as does health related quality of life. So, this brings us back. This is the patient journey, and this brings us into the shared decision making model. We need to develop a patient centered approach to myasthenia gravis treatment, where the goal is, in a perfect world, treatment goal of minimal symptom expression and minimal treatment related side effects, and focusing not just physical function, but also fatigue, sleep, and mental health. But this implies having a discussion with our patients of what are realistic treatment goals, if they are currently reaching those goals, and if not, if there is a role for initiation of a targeted therapy.
Dr. Alpers, thank you so much. That was an amazing presentation. You took us through multiple aspects of the patient journey, all of them so important. And I'm now looking forward to hearing Dr. Regal tell us about targeted immunotherapies in generalized myasthenia gravis and providing a guide to timely use and functional preservation in patients with generalized myasthenia gravis. Dr. Regal.
Great. Thank you very much. That was a perfect prelude to what we'll be talking about from Dr. Alpers about where we've come from, and this is where we're going and what we can use now. As we heard from Dr. Alpers, we really are trying to control symptoms to the greatest degree possible in our patients. We're trying to get them back to their regular life and do that while trying to minimize the side effects of the agents that we're choosing. And the goal of this in myasthenia, a disease where the direct physiology is on display in clinic every day, we're trying to maintain the physiology of the neuromuscular junction, preserve it, repair it. And I'm going to try to argue that the targeted therapies, these FDA approved therapies, are not the last resort, not something that you need to wait until the standard approaches fail. And with that, we can find ways to get patients back to where they'd like to be. And we'd like to try to do that while minimizing side effects as much as possible. So here's an overview, a nice slide of all of the different immunology and physiology of myasthenia, pointing out where some of these different agents impact myasthenia. And you can see at the neuromuscular junction, the complement inhibitors prevent the formation of membrane attack complex and destruction at the neuromuscular junction. The FcRn blockers prevent the antibody recycling and reduce the overall IgG circulating, including pathogenic autoantibodies. And then within there, at the higher level, more towards the B cells, T cells, the basic parts of the immune system, other agents and where they may play a role. And some of these are experimental therapies currently being studied, not yet FDA approved. And we'll be focusing more on the later stages of these pathways here. We'll dive into the two specific categories, the C5 inhibitors and the FcRn antagonists. The C5 inhibitors prevent cleavage of C5 into its constituent C5a and C5b, which then prevents the formation of membrane attack complex and the classical complement cascade. There's 3 drugs that are approved in this category. Eculizumab, the first FDA-approved drug in many years for myasthenia in 2017. Its very closely related cousin, ravulizumab, and then a daily injectable peptide, zilucoplan, which was approved a little more recently. And then there's the FcRn antagonist, which we saw from the prior slide. These interfere with the recycling of IgG and reduce all circulating IgG, including pathogenic autoantibodies. And there are 3 now approved in this class. Efgartigimod, which has a couple of different ways to administer it, rozanolixizumab, and then nipocalimab, which was very recently approved. So with the C5 inhibitors, all of these drugs are studied with the primary outcome being the change in the myasthenia gravis activities of daily living, the ADL score, compared to placebo. There's a few differences between how these trials were designed and the time where the outcome was measured. So for both eculizumab and ravulizumab, these are monoclonal antibodies with slightly different dosing schedules, an initial loading dose, and then eculizumab is every other week, and then ravulizumab is every 8-week dosing. These are studied in acetylcholine receptor positive generalized myasthenia only. And Zilucoplan similarly studied in acetylcholine generalized myasthenia. And the difference between these is that zilucoplan is a peptide. It's not a monoclonal antibody, and it is administered by a daily injection, an auto-injector that you give every day. And as you can see here, this is data from these randomized trials looking at the MG-ADL score. Each of them shows an improvement in the ADL score at the primary outcome. Ravulizumab there at 26 weeks, zilucoplan on the far right at 12 weeks. And you can see that fairly quickly there's a difference between these two groups. So this is demonstrating in a large population that these drugs do have something that's easy to measure, and other measurements taken as well, the QMG and other important endpoints also show some benefit compared to placebo. And I think that when you look at this and you see the change compared to placebo, a couple of points on the MG-ADL. If we're talking about these scales and quality of life, and is the juice worth the squeeze, you might argue that a couple of points on the MG-ADL is maybe that's not significant enough for the cost, the risk, the burden to move to use these drugs. The mean improvement in the clinical trial, I don't think really tells the full story. And the key is to try to find the right drug for the right patient. And one way to look at that is to look at the subset of patients who respond very well, the subset of patients who don't respond at all, and try to see, is there a way that we can figure out who is best for this. So I like these Christmas tree plots. You can see these both for ravulizumab and zilucoplan. These are reduction in ADL score, and these are the percentages of patients whose ADL score was reduced by the certain number of points there on the y-axis. So you can see of the ravulizumab group, 30% of patients or so has an ADL reduction of greater than 5 points. And then in zilucoplan, you can see a similar thing of around 30% at 5 points, 20%, 6-point reduction. So there's a subset of patients with complement inhibitors and with the FcRn drugs who have a pretty dramatic response. And then with that, we'll switch briefly to the overview of the FcRn antagonists. And again, we're looking at MG-ADL as the primary outcome. And two of these were studied looking at cycles of dosing. So efgartigimod and rozanolixizumab were studied looking at the treatment response after an initial cycle. And with efgartigimod, there's a 4-dose cycle, which is the way it's currently approved. There's been some recent study about using it every other week after that initial dosing with similar effect, but this is from the primary phase 3 trial. And at that point, 68% of patients had clinically meaningful MG-ADL improvements versus only 30% with placebo. And then rozanolixizumab has a 6-dose cycle, which again has a significant improvement at the end of that cycle. 80% had 2-point improvement or more. And then finally, the newest FcRn antagonist on the block, nipocalimab, recently approved earlier this year. This is a scheduled dosing. It's every 2-week dosing, continuously approved for acetylcholine and MuSK, just like rozanolixizumab. And then this was studied with a primary outcome at the 22 to 24 week range compared to placebo. So rather than looking at the cyclical response, this looks at the response over time. And again, you can see with the graph there on the bottom right that there is a significant difference in ADL from baseline compared to placebo. And again, we're looking at these Christmas tree plots. This is looking at the QMG just to show a different data point here that there is a significant response in an objective, very long-standing validated scale of strength and disability in myasthenia. And here you can see on the left-hand side with efgartigimod, the percentage of patients who have an improvement in the QMG by a certain number of points, up to 26% improved 10 points or more. And then rozanolixizumab, you can see there's 2 different doses in the original trial, but the 7 milligram dose is the standard dose that we use. And here you can see that there's a significant number of patients who get very significant reductions in their QMG score with this. And then a point of mention, nipocalimab and others that are forthcoming in the FcRn category. Some of them drop the IgG quantity by a pretty significant amount, and those that have a deeper reduction are thought to have an increased risk of peripheral edema and elevated cholesterol due to interactions with cholesterol handling and albumin. And generally, these drugs reduce IgG in the 60 to 75% range across the board. And importantly, this is not targeted to a specific type of IgG. This is all IgG. And for this reason, there's some increased risk of particularly upper respiratory and urinary tract infections with these agents. So now that we've seen this efficacy data, here are drugs that have been studied in fairly short time frames, some of them only over a course of a few weeks, others out to about half a year in the randomized period. So how can we use some of this data to help guide when we use these agents? So I would argue that here we are with looking at the history of myasthenia coming from limited to no treatments to symptomatic treatments, corticosteroids, the non-steroidal anti-metabolite agents. There's a lot of patients who are still not meeting their goals. And I'd argue that these newer agents don't supplant the standard of care, and they need to be used in the right patient at the right time. I'm surrounded, there's lots of military and Air Force right around where I work and lots of our patients here. I like to tell patients that these two classes are like missile defense systems. They don't really do anything at all to stop the missiles from being produced. They don't stop them from being fired, but they can shoot them down high in the air. So the FcRn antagonists reduce these antibodies, pull them out before they can have their bad action, or they can stop the missiles from causing the damage right where they land, which would be the C5 inhibitor, blocking the ability of complement to damage the neuromuscular junction. And because of that, you can't supplant the longstanding standard of care with these agents because they're so late in the pathway of this disease that you still need something to help reduce the antibody production. And there's lots of data for the prior therapies, the currently used therapies doing that, and lots more to come for all the other drugs that are in current development. So who might benefit? I think this is a partial list of patients who you might consider using some of these drugs in. And I think the biggest one is anybody who you're seeing in clinic who isn't meeting their goal, who you've tried to use the standard corticosteroids, steroid sparing agents, and they're not having the response they need. Or maybe you can't use those drugs at all. Maybe they have uncontrolled diabetes and you can't really use steroids at a significant dose. Maybe they tried steroids and it caused them to have severe anxiety or even an episode of mania. Or patients who, with the current therapies, are at risk of losing their independence, they're at risk of losing their job, becoming underemployed, unemployed. Patients who you really need to try to get better before something major happens in their life. And then the other group, I would say, are patients who I see in the hospital, patients who have severe disease coming in and out of the hospital, maybe even presenting first-time diagnosis with a hospitalization. And I think that these patients are patients you might want to think about using some of these. And both with the FcRn drugs and the complement inhibitors, several people are studying trying to use these drugs in hospitalized patients. And then how do we decide when the traditional agents aren't working? How do we decide is now the time to add something else or to switch? And I think that the key thing is if a patient can't work, if they can't eat, if they can't enjoy their day-to-day activities, you're not winning. And I think that if patients are telling you that and you're asking these questions, you're getting their quality of life scales, like Dr. Alpers mentioned, get other objective data, get the ADL score, get some quantitative strength testing, get the myasthenia gravis composite, any other tool that you can use and track patients over time. If patients aren't meeting their goals, you get the objective data, then I think you can say, this may be a patient where we need to make a move. So some potential time points to think about if you're going to start someone on the typical dosing of prednisone, they ought to have a pretty significant improvement within the first month or two. At least initially, when people start steroids, there's a little bit of a lag time before they start to work. But if you're 4 to 6 weeks in and patients are the exact same, their ADL hasn't budged, their MGC hasn't budged, you really ought to start thinking, how long am I going to keep the steroids going at this high of a dose before I wait to see a response? Because you should be seeing something by then. The non-steroid immunosuppressants, these take a long time to work. Azathioprine, 48 weeks to show a separation in the clinical trial. 6 to 12 months is what we quote for this azathioprine mycophenolate. Maybe you can wait around for that. Maybe patients can wait around for that if they're mildly effective and the steroids are working. In the past, we used to get insurance companies sending letters to us saying, we won't approve eculizumab or ravulizumab until 18 months of azathioprine. And I think those days are gone. And this is what we talked about at the beginning of my section here. Waiting until failure, I think, is not a good option. And fortunately, we don't get a whole lot of rejections based on that logic anymore. And then finally, in other patients who aren't improving, if they are admitted for exacerbation or crisis, if they are plateauing in spite of the standard therapies, these patients who you can't get extubated, you can't get them out of the hospital, they can't get out of rehab. And then finally, if the steroids are working, but you can't taper them to a safe dose, I think these are patients you really need to think about. Do I wait for azathioprine to fully reach its efficacy in 12 to 18 months while patients are on 20, 30, 40 milligrams of steroids and having side effects from them before I start to think about adding something else? And now, between these two different mechanisms, which I said are later in the stage of the immunology of this disease, how do you choose which to pick? And right now, there aren't any clear biomarkers. There aren't any obvious clinical features that have been well studied that predict whether any individual patient responds better to the FcRn blockers or the C5 inhibitors. My general approach with these two different mechanisms is to look at the patient's goals. What are they trying to get from their disease control? How quickly are they trying to get it? What the treatment burden is for the patient. Are they someone who has transportation issues and is not going to be able to go to an infusion center and get an infusion every 2 weeks or get a cycle every week for 4 weeks or 6 weeks? And also to look at the different mechanisms based on what they've previously tried and what has or hasn't worked for them. And I think that there's some way to tell a little bit about which one of these might work. So if you look at the different mechanisms, I think the big separation is that the FcRn inhibitors, up until the more recent approval of nipocalimab, are cyclically dosed. And the initial way we use these is to do a cycle of them, wait until the symptoms start to return, and then do it again. And there's a frequency with which you can do these, a minimum frequency. When they work, they really work. They are very useful for patients who are worsening, who need a fast response. Patients who need to come off of another drug, say we put them on steroids and they're gaining weight, their mood is changing, and they're having lots of side effects with steroids, and they need to come off and come off relatively quickly. These drugs work quickly and can be useful for that. And then some patients really prefer the cyclical dosing. Some patients like that flexibility to say, I'll get this drug when I need it. And then the C5 inhibitors, I think these are continuously dosed. And these patients, sometimes the predictable daily injection or the intermittent, I know that every 8 weeks I'm going to go get my ravulizumab. Sometimes that's very helpful for patients. And then I think between these two, how do you pick? The only way I can tell is that if I have had a patient who I have used plasmapheresis on and they haven't responded very well to that, I'm really not likely to expect that they'll have a significant response to the FcRn mechanism, given that they both reduce circulating IgG. And in those patients who either didn't respond to plasma exchange or to the FcRn drugs, I'm much more likely to reach for the complement inhibitors if we're not reaching our goals. And in general, I think that approach has served me well, and there's some forthcoming data to look at that as well. And then the important thing that I know we'll hear more from Dr. Narayanaswamy in a moment is that the C5 inhibitors have a particular risk for meningococcal disease, and vaccination is required. And thinking about that when you're thinking about who I might be starting one of these therapies is an important point to think about early.
Thank you so much, Tom. Wow, that was something else. You took us through 6 randomized controlled trials and then gave us a perspective of how you would approach these in this short time. Amazing. It's up to me now, and I'm going to be talking a little bit about safety considerations for selecting a targeted immunotherapy in generalized myasthenia gravis. So let's talk about this. When Josh spoke about the whole patient experience with myasthenia gravis, he mentioned how it's not just the disease that causes problems in terms of activities of daily living and quality of life and other considerations, but also the drugs that we give them. So how about the new drugs? Where do we see those going in terms of side effect profiles? So this is the data for safety for eculizumab in the pivotal Regain phase 3 study. So you will see here that overall, all as a group, both groups of these drugs have fairly good safety profiles. You will see that for the complement inhibitors, including eculizumab, the most common side effects that is occurring in more than about 10% of patients, and actually in both the drug and the placebo group, were headaches, upper respiratory tract infections, nasopharyngitis, nausea, and diarrhea. We did see a few MG exacerbations, more than 10% in both groups. They were slightly more frequent in the placebo group, and that is not unexpected. We have to remember that the inclusion criteria for this particular study had refractory patients, but obviously those are not related to the drug. There were no meningococcal infections seen here. And just to talk about this, the complement cascade and the formation of the membrane attack complex is necessary for protection from encapsulated bacteria. And these encapsulated bacteria include meningococcus, they include gonococcus, they also include to some extent pneumococcus and Haemophilus influenzae. It is mandatory, and there's a boxed warning for these drugs to actually immunize these patients before starting these therapies. And we'll talk a little bit more about that. The long-term trials of eculizumab showed pretty much similar side effect profiles. There was one patient, I believe, who had meningococcal meningitis in the long-term open label extension, but was treated, did well, and I believe went on to continue the drug. How about ravulizumab? Ravulizumab, as Dr. Rego very nicely mentioned, the cousin of eculizumab, is really just eculizumab that is engineered to last longer. So the administration is every 8 weeks instead of every 2 weeks. And as expected, again, very similar side effects to eculizumab. No meningococcal infections in the initial phase 3 champion trial. And if you look at it, any treatment emergent adverse events, 91% of patients who received ravulizumab had any treatment emergent adverse effect versus 87% of placebo. So really very close. The long-term safety, again, open label extension did not have any further signals in terms of safety of these drugs. How about the third complement inhibitor, the macrocyclic peptide zilucoplan? This is from the RAISE phase 3 study. The number of treatment emergent adverse events were pretty similar between the placebo and the zilucoplan group. The infection rate was slightly higher in the zilucoplan group, 23% versus 18%, but that was mainly driven by upper respiratory infections, not too many serious infections. Some patients, of course, had injection site bruising. This is a daily subcutaneous injection. Headaches and diarrhea were also noticed. Interestingly, there was a signal for elevation of lipase and amylase in the patients who received zilucoplan. There was also a signal for pancreatic cysts. And the recommendation is that we check amylase and lipase at the onset of treatment. We don't have to really check these during the treatment. Most of these patients were asymptomatic, so they didn't have actual pancreatitis. They just had these asymptomatic elevations. The deaths were not related to the drug here, as you can see. How about the long-term open label extension? Again, not very much different. There was one patient with esophagitis, probably not related to the drug. Again, the deaths were not related to the drug. We saw a small signal here for pancreatitis, and I believe that this was still actually elevated amylase and lipase. Where do we go with pregnancy and childbearing? Dr. Alpers mentioned how important this is and how many people actually make decisions based on their disease regarding pregnancies and having a baby. There's not a lot of data. We do have a pharmacovigilance database for eculizumab and a few patients with ravulizumab. The numbers are driven here mostly by the initially approved indications, paroxysmal nocturnal hemoglobinuria, autoimmune hemolytic uremic syndrome, etc. You'll see that the number of patients with generalized myasthenia gravis was just 92. And so although there were 2,000 odd exposures, there are few for generalized myasthenia gravis, but I do think that pregnancy exposures, we can probably extrapolate from the whole group. Unfortunately, in terms of known outcomes, we only had outcomes in the pharmacovigilance database in about a third of these patients, so approximately 600 odd patients. So we don't know what happened to the other two-thirds, and that's a little bit of concern because you wonder about selective reporting bias. And we also don't have much data about MG control, so that can also affect pregnancy outcomes. We don't know how bad their MG was. But despite these limitations, what we found was that most of these patients, 61%, went on to have live births. And that is approximately equal to the normal proportion of live births in the United States population. The spontaneous abortion rates were also similar to the US population data. For ravulizumab, it's the same pharmacovigilance database, but it's been approved later. And so the number of exposures are much more limited. We have a total of 136 outcomes, but we can't really draw very many conclusions because the outcomes were unknown in 65 of these patients. How about for zilucoplan? Zilucoplan has no human data available. There is a registry, I believe. In the product information, they had primate studies where they noted an increase in embryo fetal death at all doses in the absence of maternal toxicity in doses similar to human doses. So it's a little bit odd. Now, the USPI has this warning. Apparently, these primates, the spontaneous rate of embryo fetal death is quite high. So that's why they had a comparison group. And so it's powerful data if you do have a comparison group, but I'm not quite sure how we quite interpret it yet in the clinical setting. In clinical practice, what are some points that we consider? Because eculizumab and ravulizumab are both monoclonal antibodies, they are going to be removed if you give patients Plex. So there is a recommendation that we have to adjust the dose if we give these patients Plex. We have there's a formula for mab which is weight based, and for eculizumab you just give them an extra dose. As I mentioned, there are two meningococcal vaccines now available: pneumococcal vaccine, Haemophilus influenza is mandated in children. There is no recommendation for Haemophilus influenzae vaccination in adults. As I mentioned, there's a risk of gonococcal infections, and I mentioned the amylase lipase. In terms of lactation, there's very little data, but per the US product information, ravulizumab should be withheld for 8 months after the final dose if the breastfeeding, and should not be used during breastfeeding. Zilucoplan, there's no data. How about the FcRn antagonist? This is efgartigimod. You'll see that the number of any adverse events were actually lower in the efgartigimod group than in the placebo group. And most of these adverse events were mild or moderate in severity. Most frequent adverse events, again, noted in more than 10 or more % of patients of both groups, efgartigimod and placebo: headache, nasopharyngitis, nausea, diarrhea, and as Tom mentioned, upper respiratory tract infections and urinary tract infections. In the open label extension as well, similar side effects. In the randomized control trial, the number of urinary tract infections were double. So I think it was 10% versus 5% drug to placebo. That number didn't pan out actually, but I agree we do see these in clinical practice: upper respiratory infections, urinary tract infections, and that's something to watch for. How about rozanolixizumab? Again, mild to moderate, similar side effects. There's a rare signal. A couple of patients developed aseptic meningitis, and As you can see, headache is a feature of all of these drugs in terms of side effects. Side effects, again, in the open label extension, it seemed like younger patients and women had more treatment emergent adverse events, especially for the signal of headache. How about nipocalimab, the latest kid on the block? Total adverse events were actually very similar between groups, but there were some interesting side effects that were noted. Muscle cramps, a greater proportion, about 11% of patients versus none on placebo, actually developed muscle cramps. Infections were similar. The albumin also undergoes FCR and recycling, but it doesn't bind the albumin site. Despite that, we saw that there was a mild decrease in albumin levels, about 7.2% drop in the patients who received nipocalimab, but the levels still remained within the range of normal. They didn't fall to the definition of hypoalbuminemia. Interestingly, 11% of patients had edema, but the edema was not actually correlated to the hypoalbuminemia. So I'm not quite sure what's going on there. There was also an increase up to the order of 7 to 8% in total cholesterol, HDL cholesterol, and LDL cholesterol. The ratio doesn't change because the HDL cholesterol also increases. What this means in terms of a treatment is really not clear. How does this impact treatment? In the 26-week data, they didn't see an increase for vascular side effects, but of course, you don't anticipate seeing that in such a short duration. And that brings me actually, again, same thing, nothing unexpected in the Vivacity open label. But that brings me actually to one point. Usually, safety signals that may impact people do not often come up in the open label extensions or in the randomized controlled trials because they're still short and the exposures are small. You need a large number of exposures to detect a small signal. And so I think that is something that I actually remember in my mind, that myasthenia is a rare disease. We don't have as many exposures to be certain about these, especially in terms of the meningococcal infections. They may end up being completely safe, but we don't know that. Pregnancy data, I actually just told you this. So for nipocalimab also, it's the same data for rozanolixizumab, basically primate data. Efgartigimod is in rats and rabbits. For efgartigimod, there was no signal. For both Rosi and for nipocalimab, I think there was some concern about embryo-fetal effects or placental ischemia. Again, how this translates to the human context, it's actually very difficult to say. And for just some other clinical aspects of their use, the product information says that if you use these drugs with medications that also bind to the FcRn receptor, for instance, rituximabs and monoclonal antibody, that's going to do that. That may lower the levels of these drugs. I think it's probably likely to be the other way because the affinity for these drugs to the FcRn receptor is very high. So if you need somebody rituximab or somebody who needs IgG products for something else, perhaps these may not be the best choice. And then if there's an active infection, I will delay the dose. So you have them stop. If they call me within a cycle, I'll say stop that cycle until the infection clears. And we talked about the aseptic meningitis and lipid abnormalities. So in conclusion, just to take from Dr. Alpers and Dr. Rego's talks, both classes of drugs really quite useful. They have different mechanisms of action. And as you saw from Dr. Rego's presentation, both classes have demonstrated efficacy in randomized controlled trials and effectiveness in open label extensions. They generally offer rapid clinical benefit. I would argue with whether it's sustained. We see sometimes that patients, especially on cyclic dosing, can actually lose effect before their next dose is due. And so I would argue a little bit about the sustained. I think that remains to be seen. But the cyclic dosage really does offer a flexible dosing schedule that some patients like. We talked about the risks of infections and the other side effect profiles. There are some that are specific to each drug in each class, as I mentioned. But regardless, these targeted therapies are really an exciting development for patients with generalized myasthenia gravis. They expand the treatment options available, and there are several now ongoing studies assessing long-term safety of these agents and optimal sequencing or combination with standard immunosuppressant agents. And I think there are studies looking at multiple other mechanisms, both upstream and downstream. And I think that's exciting for us as well. And I'll stop there. Thank you for your attention.
All right. Well, thank you everybody for coming. Let's get to the questions here. Dr. Oppers, can you see the questions? And yeah.
All right, take two.
There we go. Now I hear you.
Okay, sound's coming out now. I apologize. The first question here, how should neurologists counsel women with myasthenia gravis regarding timing of pregnancy relative to disease stability? And I think that both of us can probably weigh in on this one. There's not a great answer. Ideally, if you could have the discussion to actually have a timed pregnancy where it's not an unanticipated event, that would be the ideal. As far as pregnancy data, what we've seen for eculizumab is probably of the newer agents. We have the most data. I think from my personal practice, IVIG is tried and true. And ideally, I want to shift to something such as that, but I'll defer to my colleague as well.
I think that's exactly right. You know, if you have the luxury of timing, and patients are stable, have good disease control, and they're not on a toxic medicine for, mom or baby, I think that there's, you can counsel them that it's okay to go forward this and work closely with, the OBGYN and high risk OB and anyone they need. I would say that if they are stable on an FcRn drug, those you have some potential theoretical and real risks for the fetus, particularly with maternal fetal transfer antibodies. There is good data that eculizumab is safe, effective in pregnancy. Not data yet on ravulizumab, but they're very similar, and presumably there's a registry, so presumably we'll get data for that soon.
Question number two, how quickly can clinicians expect clinical improvement with newly approved targeted therapies? I'm going to slide that question over to you.
Yeah. I think, I think that depends on the patient, depends on the therapy. If you look at the trials where they actually measured this in the FcRn drugs, even compared to placebo in the whole population, most of them at the first week, the second week, and for sure by the end of the cycle and the cyclical dosing has statistically significant improvements. And that's what you see in practice too. If a patient's going to respond to it, you'll usually know pretty quickly. With the complement inhibitors, a lot of them were not studied for outcome in the first couple of weeks. Sometimes patients who have not previously responded to plasma exchange or the FcRn drugs will respond very quickly to complement inhibitors, within days, a week. But ravulizumab and eculizumab were studied with a primary outcome at 26 weeks, about a year or about half a year. And that's usually the time I wait at minimum to say, is this a medicine that's going to work for people? But half a year is still faster than a lot of the things we used to be, stuck with our only options to use.
Yeah, and I would agree with that entirely. The other point I would make is that A lot of times the initial response is not predictive of the eventual response. And so there are some patients that will initially respond and then they have over time, you see that they have, and our data supports this as well, that they have the depth of the response you can't predict based upon their initial response. Question number 3, how do patient-reported outcomes correlate with objective measures of treatment response? I would say that it correlates quite well. And one of the reasons is if you look at any of our clinical trials that have been done over the past several years, we've moved our primary outcome measure to MG-ADL, which is a patient-reported outcome. And so I like that we're also starting to involve some things like quality of life, and that was the presentation I did, is looking at the maybe a little bit less tangible measures, less objective measures as far as impact on finances and such. But everything that we're seeing in all the newer medications, we're seeing across the board improvement in that, improvement in quality of life. And so I think that's very reassuring. Next question, do IgA antibodies have any clinical relevance in myasthenia gravis?
Maybe. There is a very recent paper from Kevin O'Connor's group at Yale in neurology, neuroimmunology, inflammation, detailing that a small subset of patients that they studied with acetylcholine positive myasthenia also had IgA antibodies, and detailing that at least in their analyses, they could potentially bind something. But we don't know if they actually have any relevance.
Excellent. Yeah, and I would agree. And IgM goes in that one as well, that there may be a component of that. I'm going to move next to, are there recommendations for sequencing or combining targeted therapies with existing myasthenia gravis treatments?
I think that I use the typical guideline approaches, steroids, azathioprine, things like that. And if people need something faster, I'll add that in later. Sometimes I'll start, those newer therapies at the same time as we start the longer term, disease modifying steroid sparing drugs. If, it's someone who was very sick, hospitalized at diagnosis or recently hospitalized, just to try to get things going. But I think, typically hewing to the 2020 guidelines and the updates, then, kind of figuring out which of the newer therapies may work then and just adding it on at that point. I think that you're going to have to balance that with, patients' particular, comorbidities and things that they, can or can't take as well.
And I would agree with that entirely, with another point being that some of the medications do have competing mechanisms of action. So for example, ravulizumab, IVIG, any of the FcRns, all of those are going to compete for the FcRn site. So definitely using caution. And I would, for example, never dose ravulizumab in conjunction with an FcRn just because any of the FcRns are going to displace it and substantially reduce the half-life of the ravulizumab. Our final question, and this one's a little bit more loaded. When initiating complement inhibitors, should therapy begin after the first meningococcal vaccine dose or only once the full vaccination series is complete? Any thoughts?
Yeah, that's a tough question, and the guidelines keep changing, and I think in the ideal situation, if you have time and the patient is stable and you don't need to start a complement inhibitor right away, ideally you'd like to have the vaccination series completed. Now, I have plenty of times when patients are very sick in the hospital, can't get off the ventilator, etc., started the complement inhibitor at the same time or, a couple hours after the first doses of the vaccine series with, penicillin prophylaxis right after. But ideally, you should try to get them vaccinated ahead of time and, use penicillin for at least a little window. In the original trials, that was 14 days. Now the guidelines are sort of a moving target, but again, depends on, patient factors. If you have a patient who's a college student or I have a patient who's a firefighter, I have kept him on, penicillin prophylaxis because he lives in congregate settings and that's a pretty risky situation.
Yes, and I would agree entirely with that. Thank you everyone for attending today. There is a QR code that is here. If you could please scan that for credit. And we appreciate your time today. We realize that you're all busy, and thank you very much.